Hi guys, welcome back to another brainstorming session where we'll be discussing MCQs of the recently concluded INI-CET November 2022 exam. Starting with the first one, a very predictable ECG based question. He said what would be the diagnosis and a couple of heart blocks and ventricular tachycardia was given. So let me just quickly count the heart rate for you guys here. Initially, I can count about three large squares between the R and the R. That will make a heart rate of 75. When I'm counting it subsequently also, I'm noticing the heart rate is 75. But then there is a bradycardia. You can notice the number of the large squares are suddenly increasing to almost 8 large squares between the two R and the R waves, which means that the heart rate of this patient at this particular point of time would be 300 divided by 8, something in the range of less than 40. Though that gives a hint to the diagnosis, but let's just work out the information. The main point that you had to notice in this question was that there was a P wave, but after this P wave, and you can differentiate the P and the T on the basis of the height, because I've explained to you vertical height of the T wave would be less than 5 millimeter, P wave would be about 2.5 millimeters per se. Now, the point is the P wave is present, but after that, it looks like there is a sinus pause because this is the time when the patient is having a missed beat slash a drop beat. So what you had to do in the exam was just pick up the missed beat present, which tells you it's a bradyarrhythmia, and option number A can be ruled out. Once you know there is a missed beat present, what you need to do is subsequently check out the PR interval after. And yes, in the actual exam, there were only 4 QRS complexes visible, out of which 3 were visible completely. One was literally, hidden in the corner, and people were still able to figure it out that this PR interval and the PR interval prior to this is equal. And the moment you are able to work out this information that the PR interval after the missed bit and the missed bit and prior to the missed bit is equal, you are having the diagnosis of this condition as Mobitz 2 heart block, and that will narrow down to the diagnosis of this patient as suffering from a variant of, Mobitz 2 heart block is a variant of second degree heart block. Let me just quickly rule out other options as well. Option number A, VT, anyway, because of the heart rate can be ruled out. First degree heart block, one of the major important diagnostic criteria would be a PR interval more than 200 milliseconds. So let's just zoom in into the ECG and count the number of small squares present here. You can count approximately about 4 small squares between the start of the P and the start of the Q, which is the PR interval, which means that the PR interval of this patient is 160 milliseconds. But for first degree heart block, I need a value of at least more than 200 milliseconds, and therefore option number B can be ruled out. We're now left between option number C and D, though we already have the answer, but still, third degree heart block, one of the important diagnostic criteria would be that the PP interval is never ever going to match with the RR interval. That's because of the AV dissociation which is present in these patients. The AV node of the patient is malfunctioning in this particular case. And another feature for third degree heart block is number of P waves and the number of the R waves will not match. So the correct answer for the first one for today is option number C, and the remaining ones can be ruled out by exclusion capability as well. When it comes to the second question, this was again from cardiology. He said in mitral stenosis, loud S1 will become soft in all of the following except. So those excepts have to be picked up anyway. In any case of mitral stenosis, there is going to be turbulence. So you would be having is a loud S1 present in patients of mild mitral stenosis. But when it comes to calcification, the main point is with calcified valve, the elastic recoil of the valve will become lesser. The moment the elastic recoil will become lesser, the intensity with which the valve is closing will also be lesser. So patients of calcified mitral stenosis would be having is a soft S1. When we look at aortic regurgitation, I'll show you a line diagram for the same. For aortic regurgitation, as you can see in the diagram, during the phase of diastole, what is happening is that the blood is leaking from the aorta back into the left ventricle, and the blood will leak, as you can see in the blue arrow. Then the pressure in the left ventricle will increase. Now, what you need to understand is that the intensity of murmur in mitral stenosis is directly related to the difference between LA minus LV. Just for the sake of mathematics, let me write this once again. Let me say this gradient is X, whatever be the mathematical value. The difference between LA and LV pressure is deciding the intensity of murmur of mitral stenosis, but aortic regurgitation will increase the pressure of the left ventricle. The moment you have is an increase of the pressure of the left ventricle, then mathematically speaking, this value of X will begin to reduce, which is why I will be having is a softer S1 in the patient. I repeat the fact once again, if a mitral stenosis patient is also having a concomitant aortic regurgitation due to increase in the pressure of the left ventricle, the gradient between the LA and LV will reduce, and this is going to result in once again a presence of a soft S1 in the patient. Well, the logic for the last option, that is heart block, is that whenever there's a heart block present, there would be a bradycardia. When you have a tachycardia, you always have a loud S1, but when you have a opposite of it, that is bradycardia, you would be having is a soft S1. So you can work out the all except MCQ in this case, that option number B, C, and D, they'll be associated with soft S1, whereas option number A, which is the answer to this question, is loud, that is loud S1 for mild mitral stenosis. Whether it is mild, whether it is moderate, but once it becomes calcified, the elastic recoil becomes lesser, which is the explanation for why, B is having a soft S1. I did decide to repeat that again so that I could re-emphasize and validate that point. The question language should be read once again before I'm just marking the answer. In mitral stenosis, loud S1 becomes soft in all the following except. So you can see that soft has been demonstrated for BCD, which is why by exclusion the answer would be option number A. So it was a bit of logic, I would say, from the cardiology perspective as compared to the first one. This was slightly more trickier one that you had to deploy some logic, and the time available is about a minute or lesser, so it contributes to mental pressure and things can go wrong. And the main focus of attempting any exam is not to crack under pressure and be able to withstand that continuously on an ongoing basis, on a MCQ to MCQ basis. You are saying, okay, my neurons are firing and I'll handle it. Coming to the third one, he says, which drug is not going to be used in the rhythm disorder shown below. So first and foremost, we'll pick up this rhythm disorder, and then subsequently, what are we going to do is work out the answer to this question. And as I've told you multiple times, what you should always do is count the number of large squares between the R and the R. And if I just zoom it in for your convenience, this would be approximately 1.5 large squares. But if I am going to scroll laterally, you will notice that the number of large squares between the R and R is rather increasing. So let me just put on some numbers here. I can count about 1.5 large squares here, but now I can count 1, 2, 3. So you are having a variable RR interval in the patient. Let me just count this once again, and you will notice that when the second time I'm counting it, the number of the large squares between the R and R is changing to about 2 large squares, and therefore the heart rate of this patient has been shown to be varying multiple times. The heart rate of this patient would be something in the range of about I would say 1.5 by 300, that would be about 200, then changing to 150, then changing to 100. So because of the fact that this is a variable RR interval, the first interpretation that I'm making is that any patient having a variable RR interval, this is going to be a possible atrial fibrillation or a multifocal atrial tachycardia. Now, how can I rule out multifocal atrial tachycardia from this situation is that I am not able to see any P waves present. If I was having P waves present, I would have said it's multifocal atrial tachycardia possibly, but because the P waves are absent in this case, all I can notice is a bit of twitching. So the rhythm disorder present for this particular question would be answered by you as atrial fibrillation. And for rate control in this patient, you will be using beta blocker like you usually use esmolol. In fact, if esmolol cannot be used, let me say, or beta blocker cannot be used because the BP is on the lower side, we might even use verapamil in these patients. When it comes to amiodarone, it is mainly used for chemical cardioversion. Though ibutilide is a class 3 antiarrhythmic drug which is recommended, but for patients with structural heart disease, amiodarone can also be used and is one of the very effective broad spectrum antiarrhythmic drugs. As I've explained, it's not only used in ventricular tachycardia but in atrial fibrillation as well. So since you are able to rule out 3 options, you can comment on the answer to this question, which would be option number B, that is adenosine. And let me give you one more reason why you should not use adenosine in any patient of atrial fibrillation. Well, the logic to be used by you here is that in any patient who's having atrial fibrillation, there is a possibility. In fact, I'll just bring this slide on focus so that you can remember this information better. In patients who are having atrial fibrillation, there might be a possibility that the person might be having accessory pathway. Yes, the accessory pathway that I'm talking about could be Wolff-Parkinson-White syndrome. So let me just write down the data here so that you can understand it. Normally, the conduction system of the heart would be the way I've shown: SA node, AV node, bundle of hairs, and then the Purkinje fiber is utilized. If a patient is having atrial fibrillation, then this AV node is the gatekeeper of the heart. I can call it unofficially the goalkeeper of the heart because it will limit the amount of impulses that will go down into the ventricles. So AV node is protective because it has a vagal innervation. It prevents impulses of atrial fibrillation. Even if its atria twitching at maybe 300 beats per minute, even then all 300 impulses would not be landing here. Now suppose in a patient who's having a atrial fibrillation, you have decided to give adenosine. and person is unfortunately, God forbid, having accessory pathway, then what adenosine will do is, I'm just putting a crosshair, what adenosine will do is it will act on the AV node. Adenosine causes prolongation of AV nodal delay. So adenosine will act on the area where I put the cross, that is the AV node, and it will stop the impulses. And if it will stop the impulses of atrial fibrillation from going down, then they will utilize the accessory pathway. You see, the current always wants to go through the pathway of least resistance. What we are having is multiple ectopic foci present in the atria in a patient of atrial fibrillation. All these impulses are landing on the AV node, and AV node will give some protection because it has a vagal innervation. But if you block it, then the current will prefer all this abnormal current of atrial fibrillation will be traveling by the accessory pathway into the ventricles and will cause degeneration of atrial fibrillation into ventricular fibrillation. Guys, this has no parallel in cardiology. I mean, the only time atrial fibrillation can degenerate into ventricular fibrillation is when a atrial fibrillation patient is having an accessory pathway and the conventional pathway was blocked by adenosine. So when you read the textbook, this is what Harrison says. He says adenosine per se, one can worsen a patient of atrial fibrillation. What he means by worsening a patient of atrial fibrillation is that it can convert a atrial fibrillation into ventricular fibrillation, provided person has a AP, that is accessory pathway. If person is not having accessory pathway, then this won't happen. But then I'm trying to give you justification. I have solved this question on two ways. One is on exclusion capability, because I know what drugs are used for rate control. C and D are for rate control. Option number A is for rhythm control. So by exclusion, I can work out D. Plus, I also explained that if, unfortunately, if adenosine is given, then it can cause deterioration as well. There would be fast ventricular rates in the patient and he's not going to survive. So again, a question which was based on ECG. Traditionally, about 2 ECGs are always asked in the exam. Sometimes it could be 1 as well. And now let's look at another ECG which was asked in, I would say, a different session. That is the evening session of the exam. He said comment on the ECG shown. So there were multiple interpretations given to me, but most of the chaps whom I spoke to, this is what they told me. I'll just zoom it in once again for your convenience. They said, sir, we could pick up a normal sinus rhythm, a PQRS, and then a T. But then, wait a minute, what's going on now? What is going on now is that this person is having a real broad RS complex with a bit of slurring of the S wave as well. You can see S wave is really broad. So this that I've shown before you in color blue is a premature ventricular contraction, and this is occurring after a normal sinus rhythm. Let me just recreate it once again. I can see a PQRST, and then once again there is an introduction of a broad RS complex, that is a premature ventricular contraction, and this is happening alternatively. I'll repeat the data once again. You are having NSR, then a PVC, you're having an NSR, then you're again having a PVC, and the diagnostic, this happens to be a diagnostic feature of I would say arrhythmia that you very commonly read with the toxicity with digoxin as well, that is ventricular bigeminy. So instead of asking you which arrhythmia is characteristic with respect to digoxin toxicity, that is or rather I would say the commonest one seen with digoxin toxicity is ventricular bigeminy, he decided to give a ECG of it. Now there is a possibility, some of people said, sir, there was also option by the name of lack of calibration. Multifocal atrial tachycardia, everybody could rule out because irregular RR interval should be there. So here we are having is a broad QRS complex, which is easily decipherable. And there is a varied morphology of the P wave for multifocal atrial tachycardia. Plus lots of time multifocal atrial tachycardia question would also be having a possible hint with a COPD patient given. So most guys were able to rule out option number C. So is the case with VT, ventricular tachycardia, because for diagnosis of VT, you need consecutive PVCs. Here, there is no consecutive premature ventricular contractions. It is alternative NSR and then a premature ventricular contraction. And what do you mean by the word lack of calibration? Let me just explain this, just in case if they decide to ask this in future. If you scan through a normal ECG, this is the norm, that on the extreme right hand side, some calibration will be given. So let me just explain what they mean by this word calibration. This calibration is to determine the paper speed. So sometimes they will write the paper speed themselves. Lots of time in your hospital, like at the lower left corner, he might have actually written the paper speed 25 millimeter per second. Or sometimes if the heart rate is very fast and we want to check out whether P wave is not present or not, we might actually change the speed of the paper of the ECG into 50 millimeter per second. So this calibration will change. So if I say irregular calibration, then irregular calibration is usually done. I mean, we don't focus on the ECG here, just focus on this rectangular mark that I have made here before you. This is the calibration. And then there can be variations in this also, because normal calibration, the vertical height would be about 10 millimeter, and this would be spanning across one large square. I mean, normal calibration marking that would always be given to you. This calibration would be one large square in breadth, and the vertical height would be 10 millimeter. But then you could be having different speeds of recording, like this, the first one that I've shown, where one large square and 1 centimeter vertical height was present towards the end in the ECG, always as a standard protocol. If this display value is not given, this means the paper speed is 25 millimeter per second. However, if you cast a glance at the second representation, you can see it's a little broader, going up to approximately 2 large squares. So this would be 50 millimeter per second. So we can vary the speed at which the paper is moving, and we can use that to our advantage, especially if there is fast ventricular rates. Then there might also be a possibility that you might be having a step ladder kind of a presentation like this. What I mean by step ladder presentation is that sometimes you might actually get a patient who's having a low voltage in the ECG. So if you're having a low voltage in the ECG, you want to amplify it. Or there's another possibility, person is having left ventricular hypertrophy, so the RS complexes are really very tall, so you want to reduce the voltage vertically, and therefore the step ladder pattern basically means that you try to reduce the voltage either in the limb lead or in the chest lead. I mean, that step ladder pattern is just to signify the reduced voltage which were deliberately done, because let me say the limb leads were showing a lower voltage. So you decided that you would just amplify that current, and therefore this step ladder pattern was present. Or you were getting very tall RS complexes due to left ventricular hypertrophy, and you just wanted to dampen the electrical responses so that they fit into the paper. I repeat once again, in left ventricular hypertrophy, diagnostic criteria SV1, RV5, V6, that diagnostic criteria, because the waves would be spilling out of the paper, you want to decrease the calibration. On the other hand, in low voltage ECG in hypothyroidism, you want to increase the amplitude so that you can decipher the complexes and the various waves of the ECG better. So that is why we play around with the calibration. And this was one of the options in the exam, so I thought I'll just speak about it. Though most guys agreed to the fact that this was an alternative NSR in a PVC, which would be a ventricular bigeminy. The answer to this question is the second one. And we move on to the subsequent one, where he said perioral numbness and tingling would be caused by all of the following except. So the characteristic presentation is that of tetany. In any patient who's suffering from tetany, there would be hypocalcemia. Vitamin D toxicity would be having calcium to be on the higher side. So this looks to be the answer, but let's look at B. Hypoparathyroidism, less PTH, less calcium. So there would be tetany-like manifestations. Hyperphosphatemia. Now, one reason why I can justify hyperphosphatemia contributing to tetany is that this can chelate calcium. It can chelate ionized calciums. I'm writing Ca2+, that is ionized calcium, and therefore tetany in the patient can be triggered. Or I can say that hyperphosphatemia is also a presentation of CKD. Every time in the routine videos or in your routine classes in medical college, they always teach you chronic kidney disease patient is having hyperphosphatemia that will be binding to the calcium component and triggering the tetany component. Plus CKD has another reason why calcium is lesser, that the kidney will not be able to produce vitamin D3, and therefore calcium would be lesser. So there are multiple reasons why I can say that calcium values would be lesser for option number C. One is the CKD component, less vitamin D3. Second is phosphate binding to calcium. In acute pancreatitis, the logic is, I mean, this is what the textbook says, that this is a extremely painful condition. So he says that during this extremely painful condition, there is release of catecholamines, and these catecholamines which are released in excess are also going to contribute to development of redistribution of calcium, which is, it causes this excess of catecholamines. It causes calcium to go inside the cells. As a result of it, if calcium is in the blood, it goes inside the cells, it goes into the tissues, and as a result of it, the ionized calcium component can become lesser. And even when you will read about Ranson scoring for a person having acute pancreatitis, though we use Apache 2, but if you read the literature apart from Apache 2, you also read about Ranson scoring. In that Ranson scoring, you will notice one of the components that is always present is serum calcium values, and calcium values are lesser in patients of acute pancreatitis. The reason what I explained was excess of catecholamines that can be contributing to this. So option number B, C, D can be having less calcium, but when it comes to option number A, there is vitamin D toxicity, which is the reason why calcium would be elevated, and therefore answer is A. I can give one more justification for acute pancreatitis. Because of the extreme amount of pain, the person will be having hyperventilation. I mean, just imagine a person who's literally screaming his lungs out because of the extreme epigastric pain. You have given opioids, but the pain is not resolving. So because you put it on yourself, when you have pain, you will hyperventilate, and hyperventilation will cause respiratory rate to increase. And whenever there is an increase of respiratory rate, there will be carbon dioxide washout, which will cause respiratory alkalosis. And if you have listened to my electrolytes video, then I've explained that alkalosis also causes redistribution of calcium, and that can explain hypocalcemia. So, I mean, primarily in any condition where person is having a severe amount of pain, redistribution of calcium is the norm. Respiratory alkalosis occurs because in pain, person will hyperventilate, and this redistribution of calcium explains the hypocalcemia and tetany-like manifestations and carpopedal spasm that could be developing in the patients. So B, C, D are justified reasons for hypocalcemia, which helps you in narrowing the answer to this question. The next one said, I would say relatively easier one, 30-year-old patient with dyspepsia and epigastric pain for past 6 months and has completed triple regimen for H. pylori. Some guy said that he had described antibiotics also, like he had written about amoxicillin, then PPI, like maybe pantoprazole or lansoprazole that was given, and clarithromycin was mentioned. So, I mean, two antibiotics, and along with that, a PPI was given to this patient, and he's saying, how do you determine the success of treatment? So for determination of Helicobacter pylori infection, we use breathuria test, and the same test is used for even determining the eradication of infection. When you go through this topic of peptic ulcer disease, when I've described Helicobacter pylori, I've said it, that the best test for diagnosis, I mean a non-invasive way for diagnosis, is a breathuria test. We can use a urease, but for urease test, you need to go in for endoscopy, take a stomach scraping, and that is how you do a urease test. So that would be relatively an invasive one, and patients would not be very comfortable sticking up a pipe down their throat. That's upper GI endoscopy. So patients prefer non-invasive, that is breathuria. And this breathuria test would also help you determine that there is an eradication of infection. And I'm just showing you a table from Harrison as well, where is mentioned that once you test positive for H. pylori, you start first line treatment in the patient. Once you've given this treatment to the patient, then wait for 1 month, so that once you have completed the course of antibiotics, I mean, you should not be having the patient on antibiotics or bismuth compounds per se. Do not give any PPI to the patient for the meantime. And after 1 month, then repeat this test. He's given two tests, in fact. One is given is urea breath test. The second then that he has given is stool antigen test. And even if, let me say, some people, maybe they might be saying, sir, even stool antigen test was given, because if both are given, then the way Harrison writes the data, he writes the most appropriate test initially. So we'll still go by UBT in this particular case. So the answer to this question works out to be option number C. The logic to be determined or used here is that non-invasive investigations are always preferred by patients over an invasive investigation. Obviously, one method of diagnosing this patient can be that I can be going in for endoscopy and check out the urease. And then the person was urease positive initially, but has turned urease positive subsequently. That means two endoscopies have to be done. And not only forget about the cost part. I mean, the forget about the cost of local anesthesia. Forget about the risks that could be present in a patient when you are giving propofol to the patient, like aspiration, etc. I mean, the point is, the person will usually not give consent to getting two endoscopies done in a span of a gap of, let me say, 1 to 2 months. More patients would be more comfortable. Most of the patients would be more comfortable for a non-invasive investigation, which is why answer to this question is option number C. Option number B, biopsy with the urease test. Then biopsy is again something which you do in a case of a, let me say, a suspected malignancy, like a person is having a gastric ulcer. And you think that there is a possible, the ulcer is not healing, or the edges of the ulcer look unhealthy, in a sense that they are different from the way they look out in a traditional gastric ulcer, because the ulcer is really small, but the edges are all, I would say, abnormally elevated. That could be because there could be a cancer hiding below it. Gastric ulcer is anyway a pre-malignant condition. So biopsy would be done in those particular cases where you're suspecting a pre-malignant change getting converted into a malignancy with respect to a gastric ulcer. Routinely, biopsy would not be recommended. Endoscopy, again, I said, I'm not criticizing endoscopy. I'm just saying that patients would not be very comfortable getting endoscopy done at least twice. Somebody might be ready for diagnosis. You might say, okay, sir, you want to do a test in me for diagnostic purposes, okay, but you want to see that whether I've responded to your treatment or not. I don't want to repeat it most of the time. So that would be how I'm ruling out endoscopy part. And yes, serology is also a good way, but then the diagnostic accuracy of this would be lesser, primarily because in India, H. pylori infection, H. pylori spreads by fecal oral route. So, this test can be positive in multiple people, and the test might remain positive even after the infection has been cured. You get cured of COVID, antibodies would still be present for a varying period of time. Similarly, here, person might have got cured from H. pylori infection after the triple regimen, the antibodies would still be present. So, all the pointers, or all the, I would say, the justifications that I have said for the various points, they all finally settle down to option number C as the best answer, and the Harrison reference is also given before you. In the next question, he says, what's the grade of dyspnea in a cardiac patient with breathlessness while he's breathless on going to the washroom? So let's look at what the data says. I can easily rule out option number C and D, in this case MMRC, because both of these are valid for COPD patients. So I'm left between option number A and B in this particular case. And the reason why I'm selecting option number B as the answer to this question can be understood from this simple data, that NYHA grade 3 would be marked limitation of activity. Now, when I say the word marked limitation of activity, it means that even routine activities like going to the bathroom or changing clothes are making the person breathless. If you look at NYHA 1, he says there's no limitation of physical activity. This guy could be climbing one flight of stairs, never an issue. But in NYHA 2, he will say, I get breathless on, let me say, going up an incline or going down or up a flight of stairs. But when it comes to activity of daily living, like wearing clothes, or let me say going to the washroom, or taking care of personal hygiene per se, and he's breathless, that would be NYHA grade 3, and NYHA grade 4 would anyway be dyspnea at rest. So the correct answer for the 7th question that I'm going to share here before you would be option number B. Moving to the next one, he said CFTR gene mutation in cystic fibrosis. He did not write the word cystic fibrosis, but it's understandable. Cystic fibrosis transmembrane receptor gene mutation involves which ion and which mutation. So it would be chloride all the way. So all options are chloride. You also know that the commonest mutation, though there are 1600 mutations which are described, but the commonest mutation is F508 mutation. So that way you can rule out at least option number C and D, where 708 is written. Now you need to select which amino acid would be affected. So I'll show you a Harrison reference for the same. He says F508 deletion mutation denotes omission of phenylalanine. And as a result of, the reference that I've shown here, the correct answer for ours would be option number A. It was more of a pediatric slash, I would say, biochemistry and a medicine based question. But then sometimes they get into these basics of genetics, which is why probably this question was put. Most guys were able to rule out 708. It was just that in 508, there was confusion between phenylalanine and tryptophan. So it's more of a fact-based question that you have to solve here. Answer to this question is alpha, option number A. Coming to the next question, a very interesting one. Absolute criteria for diagnosis of neurocysticercosis. The main thing is that by neuroimaging, you should be able to demonstrate that there is a scolex present. There was a MRI head given, and there was a non-contrast CT head also given. Now, when you look at option number B, a non-contrast CT head, you can see these hyper dense lesions, which means that these are calcified lesions of neurocysticercosis. But I cannot be sure that these are lesions of neurocysticercosis, because there are so many causes of intracranial calcification. And one of the important causes of intracranial calcification in India can be even tuberculoma. Now, because intracranial calcification can occur in multiple reasons, so per se, option number B, neuroimaging is fine. I know if I have the clinical history of the patient, if I have an MRI of the patient, then it's okay. But just by looking at these white spots, I just can't say it's neurocysticercosis, because I said one of the differential diagnosis, tuberculomas, has to be ruled out. So option number B, CT head, is not demonstrating any scolex. But when it comes to option number A, MRI head, then this is what my students told me, that they were able to, this arrow, like the weights given, was actually not given, but you can actually make up a vesicular region. So once I say that this is a MRI head and there is a vesicular lesion present in the image that is shown, so this means that there is a developing larva present. So option number A is one of the important absolute criteria for diagnosis. Then if you look at option number C, muscle microcalcification, he's talking about rice grain calcification. In the routine videos, I've shown a rice grain calcification also for cysticercosis. So option number C is not valid for neurocysticercosis. Option number C is valid for cysticercosis, which is why option number C can be ruled out. And brain biopsy, I mean, if histopathology can give us a diagnosis, that is cool. So A and D will make the cut here, which is why the answer to this particular question is option number C. And I'll just show you the reference of the textbook also. He says one of the absolute criteria for diagnosis of neurocysticercosis is histopathological demonstration of the parasite, or you should be able to on a fundus examination. I mean, there are three ways when we are 100% sure that we are dealing with neurocysticercosis. One is histology, second is going to be fundus examination showing a subretinal cysticercosis, or for that matter of fact, a Scolex within a cystic lesion on neuroimaging. And once again, I've shown you slightly enlarged images of the actual ones that were pretty similar to the ones that actually came in the exam. In one of them, we can make out, I mean, that central lesion, that is the developing worm, that's the Scolex of the worm. But on the right hand side, periventricular lesions are present, but none are having that classical Scolex appearance, which is why we can say that option number B in this particular question, CT head, would not make the cut. So the answer I would not give as option number D, A, B, C. I mean, C I've ruled out anyway because rice grain calcification is mainly for muscle microcalcification is for cysticercosis, not for neurocysticercosis. So the correct answer for this one is option number C. There was a patient who's 2 years of age with thalassemia major. He's having a requirement of multiple blood transfusions in the previous 6 months. So we are talking about a case of secondary hemochromatosis. In this particular case, he says what would be the best way to determine the iron overload in the patient. So even if you go through the main videos of hemochromatosis, the main test is serum ferritin. He's talked about liver iron concentration. Yeah, we can be doing it. So I'm just putting a plus here to say that this may be the answer to this question, may not be. Why am I discounting liver iron is because if I do a liver biopsy in a person, because hemochromatosis will ultimately contribute to liver damage and will cause cirrhosis. And if you plan to do a biopsy in a cirrhotic patient, it could be associated with bleeding as well. You might have to give fresh frozen plasma to correct the coagulogram. So the problem is why option number A is being discounted, or I would say I put a minus in front of it, is it is risky. And the reason why I've written is risky is because of the risk of bleeding. Any patient who's gonna have a liver cirrhosis, if you're gonna plan a biopsy in the patient, the risk of bleed would any day be present. Option number B is myocardial iron or a cardiac MRI. Now this is a new emerging technique. So yeah, it can be used, but at the same time, I'll do the same activity. I mean, it's not that myocardial iron or cardiac MRI would not be good enough. Yeah, it is good enough, but then you would have to rely on a new technique which may not be standardized. But serum ferritin is something which has been for ages being used to diagnose hemochromatosis. I mean, the main test that you use for diagnosis of hemochromatosis is serum ferritin, and apart from that, obviously, transferrin saturation, plus you in primary hemochromatosis, you can go for genetic evaluation as well. And if required, you might have to go in for a liver biopsy. But I'm saying the word might because if the diagnosis is not very obvious with the values of serum ferritin. Otherwise, in majority of these cases, the values of serum ferritin would be outrageously high. And option number D is non-transferrin bound iron. So a couple of people said, sir, why not option number D for this question? Yeah, the values of non-transferrin bound iron would be increasing in the patient. But we need to select a test because he said which of these is the most standardized test for these patients. So serum ferritin would be the best one that has been standardized over the large number of years for diagnosis of hemochromatosis per se. I've given the textbook reference for Harrison as well for this one. Then was a piece of cake. The following instrument would be used for, that would be a bone marrow aspiration. Option number A would be the answer to this question. You in this image can notice that there is no side screw present. So this would not be a Sala's needle. This would be a Klima's needle, which is used for bone marrow aspiration. Coming to the next one, he said cyanotic heart disease with increased pulmonary blood flow would be a feature of. Then I can easily rule out tetralogy of Fallot because this would be associated with subpulmonic stenosis, and we always read about pulmonary oligemia, less blood supply to the lungs per se, which explains the central cyanosis in these patients. So option number A can be easily ruled out. Option number B, hypoplastic left heart syndrome will mainly present in the form of shock or circulatory failure. The word is hypoplastic left heart, left ventricle is not developed. So circulatory failure would be the main presentation. We are left between two options, TGA and abstinent anomaly. Then abstinent anomaly, where we read about atrialization of the ventricles per se, there could be concomitant tricuspid stenosis. So that can explain that overall the blood supply to lungs would also be lesser. The correct answer for this question is option number B. And when you will be reading about this data in pediatrics as well, you will always read about two descriptions: cyanotic heart disease with decrease and with increased pulmonary blood flow. And let's just quickly revise the ones which are they love to ask in the exam. Where would you be having is the increased pulmonary blood flow is one, a TAPVC. Then could be tricuspid atresia with a large VSD. Now look at the differences. If you say tricuspid atresia with a restrictive VSD, then the moment you read the word restrictive VSD, it's limiting the amount of blood supply into the lungs. But there is a large VSD present in a patient that would make it increase pulmonary blood flow. Then TGA is the standard example of it, and so is truncus arteriosus. The topic of congenital heart disease is discussed separately in the app, so I would like you to listen to these mixed defects as well, with the highlight being that all of these conditions would be having is an increased pulmonary blood flow, but decreased pulmonary blood flow is a hallmark that is going to be seen with tetralogy of Fallot or with pulmonary atresia or even with tricuspid atresia for the matter of fact, but should not be having is a large VSD along with it. So the right side is relatively easy to comprehend. It's the left side that I would like you to remember. The next question was an integrated one, medicine slash microbiology. HIV positive patients with loose stools for past 1 month. The stool sample was stained with a Kinwan stain and oocysts of a particular size were given. In the morning session, it was oocyst. The size was about 4 to 6 microns, so it will turn out to be cryptosporidium. I mean, though the image was given, but simultaneously, since the diameter or the size of the oocyst was given, so it was relatively easy. And what you need to know is that if the oocyst size is between 8 to 10 microns, then it would be cyclospora. I mean, even the drug of choice would change, because if it's going to be cryptosporidium, we'll be using nitazoxanide. If it's going to be cyclospora, we'll be using cotrimoxazole. So in the previous sessions of the exam, what he's done is he has given you a particular cyst size and then he's asked you what antibiotic would be used. But in this particular session of the exam, I think it was more of a one-step kind of a question where you just had to mention the organism. And in future, if he mentions regarding oocyst, which is even bigger than 10 micron, then your answer would change over to that of isospora. And even in the routine videos I have talked about it, my suggestion to you would be do listen to AIDS topic, not from the perspective of just reading what AIDS or the treatment part, but lots of time in the exam, because opportunistic infections with AIDS are asked, so it's always a good idea to go through that, and that would help you revise your microbiology component as well. Coming to the next question, he said what drug can be given pre-operatively to reduce bleeding intraoperatively in a case of hyperthyroidism. Then the logic to be mainly used is that when you're operating upon a patient with a large vascular thyroid, the chances of bleeding would anyway be increased. So we need to shrink the size of the gland. And to decrease the size of the gland, we'll be using potassium iodine, which would be various salts that are available. Most of the time, what we'll be using is SSKI, that is saturated solution of potassium iodide, or in earlier times, they used to use Luvol iodine. The advantage of this would be that if you reduce the size of the gland, you not only reduce the chances of bleeding, but apart from this, you also decrease the chances or incidence of development of thyroid storm as well. I would recommend you to listen to the initial 5 minutes of hyperthyroidism topic where I've incorporated about this, the usage of potassium iodide pre-operatively to shrink a large vascular thyroid gland. Not only does it reduce the bleeding chances, but reduces thyroid storm incidence as well. The next question said a 30-year-old patient presents with back pain and pain in the legs on walking 100 meters. So the first thought process is maybe he's talking about Burgess disease. He also mentions that the patient has to take rest and sit down. And then comes a very peculiar statement. The question said the claudication pain improves on walking uphill as compared to walking downhill. The first impression that I get from this is that he's not talking about arterial claudication, because every time it's an arterial cause, the pain will rather worsen. Because let us assume if a person having arterial causes walking uphill, then the stress on the leg muscles will be more, the oxygen consumption by the muscles of the leg would also be more, so you need more blood supply. And with the arterial claudication, I mean, because there is a paucity of blood supply on walking uphill, the symptoms of the patient will worsen. Therefore, I can rule out Burgess disease and atherosclerosis. Both of them are responsible for, or both of them are arterial disorders. We want to pick up on neurological cause here, on neurogenic claudication. When it comes to tuberculosis of the hip, then because there would be degenerative processes in the hip joint, the person would be having pain even on standing. Here, what is happening is that the patient is taking rest, the pain is tending to reduce, and moreover, in TB hip, if a person is walking uphill, again the pressure on the hip joint, which is one of the main weight bearing joints in the body, would increase, and that will worsen the pain. It's a neurogenic claudication, guys. Right from the statement, that is, the answer would be a spinal canal stenosis or a lumbar canal stenosis. And the question in mind of most of the students after the exam was, and I got a lot of queries on the same as well, that sir, why is it that the pain would be reducing on walking uphill? In fact, people with back pain, they tend to sit with a slouch, they tend to bend forward, and let us assume this particular chap is going uphill. So when you go uphill on an incline, then you tend to apply a bit of force. When you try to apply a bit of force, there would be a slight flexion of your spine. Now let us see, let us assume that you were not doing rock climbing. I'm saying you are going on a sharp incline, then you tend to shift the center of gravity of your body a little forward by bending forward, so that you can propel your body forward. And in this particular case, when he will do slight flexion of the spine, the flexion of the spine causes a slight widening of the spinal foramina. Because of the widening of the foramina, what happens is that the pressure on the nerves will become lesser. Let's do it opposite. If this person is going down a sharp incline, he might just move his spine a little backwards, extend his spine, and when you extend the spine, it will cause compression of the spinal foramina. The pinching of the nerves would increase, and therefore the pain component in the person will worsen. I repeat once again, I said if this person is trying to climb upwards, there would be a slight flexion of the trunk. Now this flexion of the trunk, what it will cause is, it will cause widening of the spinal foramina through which these nerve roots are coming out. If you have widening of the spinal foramina, then the pressure on the nerves would be lesser, and therefore the neurogenic claudication component would become relatively lesser. So that's a peculiar presentation with lumbar canal stenosis, which mentions that the pain of the patient is relatively less on climbing uphill as compared to going downhill. Because traditionally, even in you and me, if we have to go up, it will cause more exertion. We'll feel more tired going up as compared to going down, because going down would be aided by gravity. But here opposite is happening because of this aspect that I mentioned, that the person is trying to walk with a bit of effort. So the flexion of the spine causes widening of the spinal foramina, and therefore the pressure on the nerves, or the pinching of the nerves, I would say, although it's an unofficial way of explaining it, but then the pinching of the nerves would be relatively lesser, and the pain component of the person would be reducing. So I would say again an integrated question, and the reference from Bailey and Love is also given. The next question was a piece of cake. He said child with cyanotic spells ejection systolic murmur in the second intercostal area. The moment you read kid with cyanosis, ejection systolic murmur, your mind is racing. This could be a tetralogy failure, because we are having a subpulmonic stenosis. And then he helped us with this classical boot-shaped heart, which is primarily because these patients would be having is a concentric right ventricular hypertrophy. This concentric right ventricular hypertrophy is a result of the subpulmonic stenosis, which is the hallmark lesion of this condition. The main reason for determination, or the main reason for development of cyanosis and tetralogy failure is subpulmonic stenosis, plus the compensatory right ventricular hypertrophy that occurs, the concentric variety that pushes up the apex of the heart. So we get a boot-shaped heart, which is a feature of tetralogy failure. So already mentioned it because I think this was one of the easier questions. The subsequent one that I'm discussing with you, again, I marked the answer because that's very traditional information that I always speak, that all shocks would be having tachycardia, but which shock would be having is a bradycardia. That would be neurogenic shock, like a person had damage to his spinal cord. That's what Bailey also says, that if a person is having neurogenic shock, then the unopposed vagal activity would result in a bradycardia. And he says that in any patient who, in fact, I can just jot it down as well, that all shocks would be having is a tachycardia, but the only shock with a bradycardia is neurogenic shock. Similarly, another question has been asked in the previous years. When I write it, I hope that you can just spot on, come up with the answers there also. Which shock would be having is a elevated CVP. Because normally with CVP, we always read about a reduction, but like in hypovolemic shock, but in cardiogenic shock, you will be having is a shock with increased central venous pressure. And when it comes to shock with bradycardia, then it is neurogenic shock. This guy, he fell from a height and he fractured his thoracic spine. Now T1 to T6, they provide sympathomimetic stimulation to the heart, and if the sympathomimetic stimulation is gone, then the parasympathomimetic activity will override it, and therefore the bradycardia component would come up. So the answer to this question is a relatively easier one. That would be option number A, and that is why I had highlighted it. I mean, there are some questions in the exam that you would literally be rushing through them because they are very straightforward. The next question, again, I've incorporated, though even the physiologist would be talking about it, airway pressure at which in the pressure volume curve, the recording at the mouth will become 0. Now, my point is you can solve this question either on physiology or on basis of, I would say, spirometric interpretation. I mean, we always read about this kind of a spirometric interpretation where we have is a inspiratory reserve volume. The one that I'm marking at the moment, this would be IRV. Then we have is a tidal volume, then we have expiratory reserve volume, and still there will be some air remaining behind in the lungs, that would be residual volume. Now the combination of these two is what is called as FRC, that is functional residual capacity. FRC is a combination of these two, that is expiratory reserve volume and the residual volume. So let us assume that if I have no knowledge of physiology, how would I solve this question? This would be the baseline, no? This is the baseline that I'm showing at the moment, and around this baseline you're having a tidal volume IRV. So because this is the baseline, I can take this as a reference value of 0, and over and above this and below it are certain values which are mentioned. So the correct answer for where the pressure recording in the mouth would be 0 in a pressure volume curve would be functional residual capacity. I said one way to crack this is guesswork, which is that this baseline that I mentioned before you is the time when we are talking about the combination of these two parameters, that is functional residual capacity. Or for that matter of fact, another way to solve this question is hardcore physiology. And this is what physiology says, that the outward pressure and normally when you breathe in and then subsequently there's the expiration, there is an elastic recoil of the lung. In fact, this is what he says in physiology, that functional residual capacity is the volume at which the elastic recoil of the lung, because every time when we breathe out, there's an elastic recoil of the lung. So the inward recoil of the lung balances the elastic recoil of the chest wall in an outward direction. So he says there's an inward pull, there's outward pull, and the balancing of the two occurs at functional residual capacity. The correct answer for question number 18 is already highlighted, that is option number B10. And I've tried by two ways to explain this to you, though you can listen to the physiologist about it as well. Coming to the next one, which is hardcore general medicine or neurology, he says a person has brought his dad who's 60 years of age and is complaining that his dad is having weakness in left side of the body. He's saying his dad is shaving only right side of the face, does not bath the left side of the body. So the basic presentation that is given in this question is that of hemi-neglect. And as a doctor, as a physician, every time you get a patient of suspected hemi-neglect, what you will do is maybe draw a clock like this and ask the person to draw a clock. You can even make the needles in the clock and tell him that, okay, draw this time. And what you will notice is the person would be drawing only, let me say, half of the clock. Some part of the numerals may be given, even the needles may or may not be drawn. So the classical presentation is that of hemi-neglect, which is a presentation that is seen in patients who are having damage to their non-dominant parietal lobe. Now in this particular case, if I look at option number A and B, frontal lobe, whenever you are having frontal lobe involvement, there is always an aggressive behavior and urinary incontinence. None of these are given in this question. Plus these patients would be having a magnetic gait. So whenever it's a frontal lobe involvement, I said it's a bladder issue that comes up, personality change in an individual, and there would be a magnetic gait. None given in this question. So A and B can be ruled out. How do you select between C versus D? One is simple logic. If the weakness is in the left side of the body, then the involvement will be on the right hand side. And in this particular case, another way to get the question right is that hemi-neglect is a classical presentation that is seen with parietal lobe involvement but non-dominant, because dominant parietal lobe involvement will mainly contribute to aphasia. But when it's a non-dominant parietal lobe involvement, there would be hemi-neglect as an important presentation in the case. So this was, I would say, a question which had maybe 4 or 5 lines, but if you could just pick up the hemi-neglect component in the question, it was relatively a simpler one. The next question said hagma, that is high anion gap, would be seen with which condition? So every time you read about a hagma, that would be a metabolic acidosis in a patient. The normal anion gap values would be given by you as 6 to 12 milliequivalents, and whenever we have hagma, there could be multiple reasons for it also. Like one of the mnemonics that I mentioned to describe HAGMA would be ketoacidosis, uremia, lactic acidosis, and toxins. So you can go through in the main section of the app, HAGMA and NAGMA, that is normal and ungap versus high in ungap metabolic acidosis. But this was, I think, again, one of the easier questions, which explains why the strike rate or strike rate of students was good, and even the score cutoff went a little higher. Now in 21, he says which of the following is seen in primary hypothyroidism. Multiple permutation combinations were given. When you read the word primary hypothyroidism, it means that the gland is not working, gland is not producing T4 and T3. And what are you gonna check for? Not the total T4 and T3. I mean, when you say hypo or hyper, it is based on the free values per se. So the first thing that I can pick up is that I need to select an option where there would be low T4 and T3, and that's what I'm picking up in option number A. Let's read forward. So reverse T3. Reverse T3 is the inactive format, which is normal in this case. Total T4 and T3 can be normal in hypothyroidism. Whether it's primary or secondary, separate issue, but T4, T3 total values can be normal. It's the free values that are of concern. Free T4 and free T3 are the ones that you will mainly check in the report. And in this particular chart, free T4, T3 are lesser. And by feedback mechanism, the TSH of the patient is elevated. So the correct answer for this one would be option number A, but let's read B. The problem with option number B is that free T4, which is the main produce for the gland, is normal, because you know that T4 is produced by the gland. In the blood, it is converted into T3, the free T3 format, then subsequently is generated. But the point against the answer as option number B is that T4 values are normal, whereas T4 values should be lesser. Another point against this would be elevated values of reverse T3. In fact, where do you have elevated reverse T3 and a low T3 with a normal free T4 values is where there's a defective conversion of T4 into T3. I repeat once again, we are aware that T4 undergoes peripheral deiodination. There's enzyme D1 deiodinase that you read in biochem, which causes conversion of T4 into T3 in the peripheral blood circulation. Now, my point is that if a person is having an intercurrent illness, there can be release of cytokines that can inhibit this conversion. The active form of thyroid hormone, that is T3, will be produced relatively lesser. The condition that I'm talking about, where with the intercurrent illness, a person is having low T3. It's not that T3 is being produced less. It is the conversion of T4 into T3 that is being hampered. This condition that I'm writing before you, sick euthyroid syndrome, has a characteristic feature that the conversion of T4 into T3, the active format, is lesser. Rather, this gets converted mainly into the inactive form of thyroid hormone. The inactive form of thyroid hormone, which is usually written as reverse T3, is the one which is elevated in these patients. So the profile which is given in option number B for this question is for patients of sick euthyroid syndrome. Option number C and D can be straight away ruled out, because in hypothyroidism, you would not be having is a high value of free T4 and free T3. So C and D were anyway off my radar. I was focusing between A versus B, and the correct answer for this one is the first option of this question. The next question again had a physiology overlap, so I thought I'll just give up the answer here, and that would ease off the pressure on me and I can do the explanation part. He said, in absence of ADH, the fluid leaving the proximal convoluted tubulus. Now, a simple question, because antidiuretic hormone will mainly be acting on the collecting duct and some part of the distal convoluted tubule. The point is, antidiuretic hormone has nothing to do with proximal convoluted tubule. Agreed that if a person is having absence of antidiuretic hormone, there would be diabetes insipidus in a patient. So when I'm talking about diabetes insipidus, yeah, I do have a dilute urine, but where is the problem located? The reason for the dilute urine is not problem with respect to the PCT. PCT will be doing its job. It is the CD and the DCT which are not doing their job. So as such, the urine that is, or the ultrafiltrate, when he's saying fluid leaving the proximal convoluted tubule, is talking about the ultrafiltrate. So the ultrafiltrate per se is going to be isoosmolar. I also have a diagram to support this, that the fluid that comes out of the PCT will be isoosmolar. Then for the thick ascending limb of loop of Henle, this would be hypoosmolar once again. And in collecting duct, if he specifically talks about collecting duct per se, then in the absence of vasopressin, it would be hypoosmolar. And if it's going to be SiADH in excess, then there would be a hyperosmolar osmolarity per se of the tubular fluid or of the ultrafiltrate. I would suggest you to listen to diabetes insipidus and SiADH comparison as well from the endocrine section. In fact, I've covered it even in the kidney section with the Bartter and Gitelman syndrome. So just go through that and you'll realize that the primary reason why the question was asked was that he just wanted to see that do you know the site of action of antidiuretic hormone. The next question says a patient is presented with ischemic stroke, thrombolysis would be contraindicated. Option number A talks about age more than 18 years of age. So I'll just put an alphabet I to say that this is the indication. I mean, a person lesser than 18 is a contraindication, but age more than 18 is an indication for stroke. Let me just show you the reference also. This is what the textbook also says, that age more than 18 years of age, and if the person is coming within 4.5 hours, we should be doing is the thrombolysis, and obviously there should be a clinical diagnosis of stroke in the patient. For this particular option, I'll come back to this slide once again, but I just want to say that we do thrombolysis within a window period of 4.5 hours and the age of the patient should be more than 18 years. So two options here would be straight away indications, that is option number A and C. In C, I'm saying because patient is presented in 3 hours. So earlier the patient comes, more neurons I'm able to say. Now, if I look at B, he says blood pressure more than 185 by 110 millimeter of mercury despite treatment. The problem is if I do thrombolysis with this higher BP, it will increase the bleeding incidence. It will increase the chances of development of CNS bleed in any person. So the message is that blood pressure should be brought down by giving labetalol. I mean, it will take you 10 minutes of administration of labetalol. You can bring down the BP to respectable value and then you can do thrombolysis. So option number B per se, I will say, is a contraindication. It's a contraindication to doing a thrombolysis in an individual. Let's read up D. He says CT scan showing no hemorrhage or edema greater than 1/3 of the MCA territory. The point is the no word is important in this particular case. If a patient is having even a normal CT scan, there's no hemorrhage, there is no edema, the edema component might take some time to appear, but even if it comes, you need to understand it should be within less than 1/3 of the MCA territory. And how do we know whether it's more than 1/3 or less than of the MCA territory? So we can do the CTP, that's a CT perfusion study, and we can measure the size of the infarct. Guys, what I want you to remember is that whenever there is a large infarct present, then if it's a multi-lobar infarct, it's spanning across multiple lobes of the brain, or if there is a large infarct present, and if you do thrombolysis, I said, if you do thrombolysis in a guy with a large infarct, there is increased incidence of hemorrhagic transformation. There is increased chances of bleeding within it. So the first thing that I want you to remember is that whenever you are doing thrombolysis, you can do thrombolysis if CT scan is normal. One, because if the symptoms of stroke are present, because findings will take some time to appear. But do not do thrombolysis in a large infarct. The definition of large infarct I mentioned was if the size would be very, very large to the extent of more than 1/3 of the MCA distribution per se. I'll just show you the table here also. He says CT scan. This is the exact line which was mentioned, that CT scan showing no hemorrhage or edema greater than 1/3 of the MCA territory. Here, don't focus on this word greater than, focus on this word no, because this basically means the infarct should be lesser than this. The English meaning of this is a smaller infarct, you can do thrombolysis. In large infarct, multi-lobar infarct, if you do thrombolysis, it will cause an increased risk of hemorrhagic transformation. So this line to line statement was the one that was replicated. CT scan showing no hemorrhage or edema greater than MCA territory, which basically means that the infarct is less than 1/3 of the MCA territory. I mean, the meaning of this statement is less than 1/3 of the MCA territory. So this is again an indication for doing thrombolysis in an individual. There are 3 indications that I've discussed in this particular question. But if a person is having extremely high blood pressure, I would first like to use labetalol to decrease the blood pressure and then proceed with thrombolysis. The correct answer for this question will be option number B. The next question was a physiology based one. He said there was a clinician who's performing an ankle jerk. The root value will be S1. And he said, when would this be exaggerated? Exaggerated would mean that when would you be having is a brisk ankle jerk. So that would be a case of upper motor neuron lesion. And upper motor neuron lesion, because you have loss of inhibitory control, as a result of which the reflexes tend to become relatively faster. And that is why we either use the word brisk, or sometimes we might even use the word clonus to describe a ultra brisk, ultra fast deep tendon reflex in a patient. And in the evening session, he gave the classical dorsiflexion of the great toe and fanning of the smaller toes. You can see the smaller toes spreading out, fanning of the smaller toes, and dorsiflexion of the big toe. That is Babinski sign, which is a feature of upper motor neuron lesion. So, I mean, a couple of questions were so simple that people were saying like it was maybe we are sitting for some very easy exam. That was the thought process, but then suddenly they made a couple of questions tricky as well. Coming to the next one, which was more of a conceptual one, he said presence of which of the following will help you determine a hepatitis B and D co-infection and exclude hepatitis B, D super-infection. I think in the morning session, they had mainly asked about the co-infection component. In the evening, they talked about super-infection. So let's get the concept right. If you just go or focus on the English word co-infection, it means that there would be acute hepatitis B and acute hepatitis D present in the patient. I'll just give an example so that you can solve this question relatively better. We have a IV drug user, and because of needle sharing, he has developed acute hepatitis B. So he's surface antigen positive, and also present in his body is IgM class of antibody to the core antigen. Now this guy who's doing needle sharing has changed his group and he got hepatitis delta infection from a different group where he was doing needle sharing, and now this person is having IgM class of antibody to hepatitis D virus as well. So you can see two IgM class of antibody present in this patient, which would help you determine a co-infection. Now, what is a superinfection? So I'll just use an alternative color to highlight it. In superinfection, the person is having already chronic hepatitis B. Already his liver is damaged. And in this guy with chronic hepatitis B, there is a new onset hepatitis delta infection. So in chronic hepatitis B, you would already be having is a IgG class of antibody to the core antigen. So you can solve both the questions because in superinfection, there would be IgG class of antibody to the core antigen. He's asking you what the question that I framed before you was how do you determine a co-infection? That would be mainly presence of IgM class of antibody to the core antigen. So the correct answer for this question would be beta, and I'll just show you a table to highlight this. And in this table, it's mentioned that if it's a co-infection, IgM class of antibody to the core antigen, IgM class of antibody to delta would also be present. And the main point that helps you in identifying co-infection is IgM class of antibody to the core antigen. The same one, once it is negative and it is IgG class of antibody that is positive, then this would be with superinfection. The bottom line is that superinfection is seen with chronic. So IgG class of antibody, IgM would be absent, and if it is going to be co-infection, then two IgM class of antibodies would be present, because in the morning session he was saying co-infection is diagnosed by it is presence of this antibody. In superinfection, the same antibody would be absent. Coming to the next one, he said a child is presented with a severe acute exacerbation of asthma with a SpO2 of only 80%. I would classify that as a life-threatening attack of asthma, considering the SpO2 is down to 80%, and he says all of the following would be done immediately except. So option A is chest X-ray. We routinely do not do a chest X-ray in asthmatics, only if you are suspecting maybe a concomitant pneumonia. It could be a bacterial pneumonia or COVID-19 pneumonia. You might do a chest X-ray in a patient, but routinely, I mean, you would straight away nebulize the patient, give steroids, and give high flow oxygen to this person. Though I would like to show you a reference for the same as well. When would I say patient is having a life-threatening asthma? When any one of the following is present. If the lips are turning blue, oxygen saturation is down to 80%, peak expiratory flow rate is so bad that he can't even blow into the peak expiratory flow rate meter. PEFR is less than 33%. If there's a silent chest, so they don't use words like status asthmaticus anymore. We do read about words like acute asthma, severe asthma exacerbation, life-threatening asthma. When it comes to severe asthma in a patient, there would be pulsus paradoxus may be present. Person would have difficulty in talking, but there would not be a silent chest in the person. If you get a silent chest, that means the guy is really, really deteriorating. In this particular question in your exam, he did not talk about silent chest. He did not say the word status asthmaticus. He mentioned oxygen saturation to be less than 80%, which I said is life-threatening asthma. And then what I'm going to do in this guy right away in any patient life-threatening asthma, as you can see in the slide, we need to give nebulization with salbutamol with ipratropium. Obviously, ipratropium will take its own sweet time to act. We also need to give oxygen to this patient, and simultaneously we need to give steroids. When it comes to the administration of steroids in these patients, we could be using injection Dexona, that is dexamethasone. If you have methylprednisolone available, great. Otherwise, like in government hospitals, when we don't have too much available, we might be using hydrocortisone or we might be using oral prednisolone. The standard dose in children is 1 milligram per kg. Here we'll be giving 2 milligram per kg for a life-threatening asthma attack in an individual. These are like standard approaches that you do in the casualty, but you do not regularly order a chest X-ray in the patient. So the correct answer for question number 27 would be option number 3. Question number 28 was based on ventilator settings and ABG values. This was a lady 35 years of age who was suffering from ARDS. She was having hypoxia. PCO2 was normal. So as I've explained in a routine video as well, that ARDS is an example of type 1 respiratory failure, where obviously the values of PO2 would be lesser, but PCO2 values would either be normal or can be lesser than normal. So here the PCO2 is on the lower side of normal. She's already on the ventilator. Her FiO2 is 90%. So look at it. We are giving her a FiO2 90%, fraction of inspired oxygen 90%, but in spite of that, her PO2 is down to only 50. PEEP is peak and expiratory pressure, that is 5 centimeter of water. Our inspiratory expiratory ratio is traditional 1:2, and he says, what would you do in this case? Option A is increase tidal volume. In any patient of ARDS, if you increase the tidal volume, there will always be an enhanced risk of development of pneumothorax. In fact, in COVID, we saw that when we were putting patients on ventilator, lots of times when these patients were going into ARDS, they were having a pneumothorax. So increased tidal volume is not recommended in ARDS. Rather, it is low tidal volume ventilation that is used. Even in the routine video lecture, I've explained it. Low tidal volume ventilation is what you should be using. So option number A is ruled out. B says increase PEEP. It makes sense. The logic behind increasing the PEEP in the patient is that peak and expiratory pressure, if you increase, it will prevent the expiratory collapse of alveoli, and he's using a technical term, recruitment of the alveoli. What he means by recruitment of the alveoli is that if you are gonna enhance the PEEP, there would be more surface area available for gaseous exchange. I said recruitment of alveoli means that there is an increase in the surface area which is currently available for gas exchange, and therefore the oxygen saturation of the patient should logically improve. So B looks like a possible answer. Let's look at C, decrease FiO2. FiO2 90% is fairly high. I'm risking oxygen toxicity. If I decrease it further, then the person will worsen. I mean, most patients of ARDS are having, in spite of giving supplemental oxygen, in spite of going in for non-invasive ventilation in these patients, they might even be, you might be generating a FiO2 90%, but still there is hypoxia because the alveoli are collapsing. So decreasing FiO2 would not be advisable in this case. If it was increasing FiO2, that would have made more sense, but decreasing FiO2 would rather worsen or deteriorate this patient. If you look at option number D, he says change the inspiratory expiratory ratio to 1:3. Then this is what you do in asthma or COPD patients, because in asthma or COPD there is a prolonged expiration. So to take care of that prolonged expiration, we might change the inspiratory expiratory ratio to the values that I mentioned. So D is also ruled out. The correct answer for this, as I had anticipated earlier, would be a increased value of PEEP that will cause increased recruitment of alveoli, more surface area for gas exchange, and better PO2 values. For the same question, I'm also showing you a Harrison reference where he says this statement. He says, without an increase in the end expiratory pressure, significant alveolar collapse can occur, and there can be an impairment of oxygenation. So in most clinical settings, he's saying that positive end expiratory pressure or PEEP is adjusted to minimize the FiO2. I mean, I need to go in for recruitment of the alveoli, as I mentioned, without causing a alveolar overdistension. And I'll just move up in the slide and mention regarding that low volume ventilation concept that I was saying. In fact, this ARDS network, the name of which is described here, has described a low tidal volume with a value of 6 ml per kg. Traditionally, the conventional, as you can see, conventional tidal volume ventilation is 12 ml per kg. The kilogram denominator is for the predicted body weight of the individual, that is lean body weight of the person. And instead of doing a traditional, like in Guillain-Barré syndrome, if a person is not having any lung disease but is having requirement of ventilation because there is a muscle paralysis, diaphragmatic paralysis, the ventilator settings would be 12 ml per kg. But in a chap with post-COVID-19 ending up with ARDS, or sepsis contributing to ARDS, Mendelssohn syndrome contributing to ARDS, we'll be using is 6 ml per kg. That's mainly to minimize the barotrauma aspect which I've highlighted. So I've provided references for the answer for this question from the textbook. The correct answer for question number 28 would be option number B. The next question was from rheumatology, where he described a woman with photosensitivity on the sun exposed parts of the body. That would be like the cheek of the patient, neck of the patient, and she was also having shortness of breath on climbing a stairs. Now, one of the reason for this shortness of breath can be that there could be lung involvement, because anyway he's talking about a connective tissue disorder, and he had also given an image of the dorsum of the hand. Now, if I zoom it in, most students were initially saying, sir, we thought the traditional Gottron papules. But yes, there was one more question in pediatrics for Gottron papules in juvenile dermatomyositis. But in this case, you could make up from the nails of the patient that this is a female patient. And then there would be this red marks which are present, which are those of photosensitivity itself. I mean, when the patient goes out in the sunlight, there could be a sunburn on the sun exposed parts of the body. So photosensitivity and shortness of breath, the combination of the two, you need to think in terms of possibility of SLE and one of the entry level criteria. I mean, he's saying which antibody is used for diagnosis. So the traditional statement is entry level criteria for diagnosis of systemic lupus erythematosus is anti-nuclear antibody. The correct answer for this question would be option number B. When it comes to double-stranded DNA, why it is not the answer? Well, double-stranded DNA is used to monitor the severity of disease. Like in SLE, there would be exacerbation, or there would be a worsening, and there would be waning of the disease. So it has a waxing and a waning course basically. So severity of disease per se, like is it improving on my medication, or is it worsening in spite of medication, that would be double-stranded DNA. Anti-centromere antibody would anyway be used for diagnosis of CREST syndrome, anti-stone antibody for drug-induced lupus. So the remaining options can be ruled out. I mean, the traditional question in the exam is entry-level criteria for SLE. He just disguised it in the question by not describing the word SLE per se, but he described photosensitivity. And how do you explain the shortness of breath? Then I can say that there could be a pleuritis component present in the patient. There could be a pleural effusion developing in a patient, and that could explain the shortness of breath. Or even you read about shrinking lung syndrome. When I say the word shrinking lung syndrome, the English version of it would explain that there could be shortness of breath experienced by a patient. So this was anyway one of the, I would say, less common presentation of the disease. But photosensitivity on the sun exposed parts like the cheeks and the neck and then the hands of the patient, the dorsum of the hands, which was the image perspective, would help you in coming to the diagnosis, and the answer to this question is option number B. In the evening session, the image that was given was of salt and pepper skin. There was no, I mean, the question was from rheumatology only, but there was a dorsum of the hand that was shown, and then the skin in some areas was relatively darker. As you can see, I'll just zoom it in further, darker, so salt and pepper skin. And once I'm writing it, all of you know the answer to this, that this would be a feature seen with the systemic sclerosis, SSC, as they call it, or they might even use the word diffuse scleroderma for this presentation. So salt and pepper skin is and the antibody. I mean, he probably maybe gave a image like this, and he said what antibody would be useful. He might have twisted the options. That would be anti-topoisomerase antibody is the best way to identify scleroderma per se. And the reference for lupus photosensitivity anti-nuclear antibody entry-level criteria is what I've shown at the moment before you as well. The subsequent question had a physiology-based overlap. What is correct about cerebral perfusion pressure? Then CPP is a difference of mean arterial pressure and intracranial pressure. Suppose your mean arterial pressure is calculated on the basis of systolic plus 2 times diastolic, whole thing divided by 3. So if you take values of 120 by 80, the map would come something like 95. Normal intracranial pressure, I'll just write down the value. Normal intracranial pressure is between 10 to 20 millimeter of mercury, and I'll just take an upper limit of it, that is 20. So yours and my cerebral perfusion pressure would be approximately 75 millimeters of mercury. I mean, that's the pressure with which the perfusion of the brain is occurring. And the importance of knowing this is that if intracranial pressure will increase, if mathematically this intracranial pressure will increase because of head injury, then what will happen to cerebral perfusion pressure? Then it will reduce. You see, if I increase this from 20 to 30 to 40, if I subtract 40 from 95, it will obviously be lesser, no? So raise ICP, why it is dangerous? Because it causes a reduction in the value of the cerebral perfusion pressure of the patient. The correct answer to our question is option number B. And the logic, and I presume why he put up that question was that he, in a rush to answer, people did answer systolic blood pressure minus intracranial pressure. No, it's not systolic blood pressure, it is mean arterial pressure, and this formula is directly from Genau. 31 says a 50-year-old male presented with left-sided hemiparesis, damage to which part of the internal capsule will lead to this presentation. So he's talking about pure motor paralysis. Whenever we have pure motor paralysis in an individual, it means that internal capsule is involved. Now, what is going to be involved in the internal capsule? We have an anterior limb, we have a genu, and then we have is a posterior limb. And as you know from the representation from even your anatomy classes, that if it is the genu that is involved, then it would mainly be face weakness in individual, tongue weakness in a person contributing to dysarthria. But if it is the posterior limb that gets involved, then the major manifestations of the patient would be arm and a leg weakness. So the correct answer for this one would be posterior limb involvement. And I'll just make you practice this. The main information to be remembered by you is that if the anterior half of the posterior limb is involved, then it can contribute to pure motor paralysis. Obviously, I mean, it would be contralateral to the site of the lesion. The message is that if there is going to be damage to the posterior third of the posterior limb, get the words right, posterior third of the posterior limb, then it can result in contralateral hemisensory deficits. So you could be having is a pure motor involvement, or you could be having is a pure sensory involvement in a patient. I repeat once again, pure motor stroke or pure sensory stroke is always internal capsule. And where is the lesion present? The lesion is always in the posterior limb. I repeat once again, when you have is a classical hemiplegia, face weakness, arm weakness, and leg weakness in one half of the body, there is no aphasia, no apraxia, none of those A is present, then it's not a cortical stroke. Then it would be an internal capsule stroke or a subcortical stroke in a person. The correct answer for this particular one would be option number D, and I just showed you a reference for the same as well. The Harrison reference is what is highlighted. If the lesion is in the genu, then it can contribute to facial and a tongue weakness. So there could be dysarthria manifestations occurring in the patient as well. So you just need to get these facts right. In anatomy, they are mainly focusing on the blood supply of the anterior limb and the genu and the posterior part or the posterior limb of the internal capsule. But from the medicine perspective, I mainly want you to remember these words: pure motor paralysis and pure sensory involvement. Anterior half of the, remember, it is not anterior limb, it is anterior part of the posterior limb, and then is the posterior part of the posterior limb, which is to be remembered by you for pure motor and pure sensory stroke. However, he did not write that word because then it would have been relatively easier for you, so he put up this word hemiparesis and subcortical stroke presentation asked as internal capsule involvement. Answer to 31 is D. Moving to 32, he says a child 10 years of age presented with hemiplegismus. The moment you read the word hemiplegismus, the question is correct because hemiplegismus would be a sudden onset, wide, flailing movements of arm and the leg, and hemiplegismus is always a feature of subthalamic nucleus. Caudate nucleus involvement would obviously contribute to chorea in a person. Substantia nigra involvement will cause Parkinsonism disease in a patient. If thalamus is involved, then there could be issues with the sensory relay to the brain of the patient as well. There could be Dejerin-Rossi syndrome where the person, even if you have, let me say, water falling on the hand of the patient, he might say that I feel as if there is acid falling on my body, or I feel as if somebody is tightening a metal wire around my body. So, excruciating hemisensory pain is Dejerin-Rossi. That would be thalamic involvement in an individual. However, this was relatively easier. Involuntary movement, basal ganglia involvement, hemiplegismus due to involvement of the subthalamic nucleus. Then is the traditional question that always comes in the exam: 15-year-old guy with hepatomegaly, involuntary movements, and poor scholastic performance. So he's talking about liver involvement and then neurological involvement. The moment you read this and you get jaundice in the person, there is some students said that the ring was very visible. That is, as you can see in this image, the greenish white ring, that is KF ring. So the question can be correct on the basis of combination of lenticular degeneration. He is not specially mentioned regarding lenticular nucleus involvement. But my point is, if you are having a liver involvement, a basal ganglia involvement, and a KF ring present, then the combination of these two would The cave ring obviously predominantly would help you in identifying that this is Wilson disease per se. The correct answer for 33 is option number B. Moving to the next one. A 40-year-old female has had multiple episodes of vomiting and loose motions. She was managed at the periphery by administration of IV fluids and hyponatremia was corrected. Now she is presented with paralysis, dysarthria, dysphagia, loss of consciousness. So stroke-like manifestations are there. And the moment you read that a person who was having electrolyte imbalance, this lady was suffering from dyselectrolytemia, and she was given IV fluids, probably too fast, which has resulted in stroke-like features. The clinical diagnosis would be osmotic demyelination syndrome. In earlier times when I was a student, I used to read, at your age, I used to read the word central pontine myelinosis, but now that word central pontine myelinosis has been replaced by the term osmotic demyelination syndrome. The reason for this is that if you correct sodium very fast, the correction of sodium on a daily basis should not be more than 8 milliequivalents. Like suppose patient got admitted with a sodium value of 120, then you will not straight away in 24 hours upgrade from 120 to 135. You will upgrade in 24 hours from 120 to 128. From 128, you will jump another 8 points in the next another 24 hours. So over 48 to 72 hours, I would like to gradually increase the sodium values in the body of the patient from 8 milliequivalents per day, in increments of 8 milliequivalents per day to 120, 128, and then 136, instead of doing it fast. If you do it fast, you have osmotic demyelination. So rapid correction of hyponatremia is the villain in this case. Though in previous years, he has asked a little more difficult by asking you the correction formulas, which are also discussed in the previous papers. Here he simply asked you regarding the pathogenesis of osmotic demyelination syndrome. The answer is rapid correction of hyponatremia causes damage to the myelin due to fluid shift across these cells in the brain, and thereby neurological manifestations, corticospinal pathway gets demyelinated, so you get neurological manifestations and even speech deficits with paralysis would be seen. Answer to 34 is option number C. Coming to the next one, this was an evening session question which was opposite to a question that I mentioned earlier where tetany-like manifestations was asked. Here he asked hypercalcemia would not be seen. So calcium metabolism is what was being asked, and he's saying is not seen in which of the following conditions. So vitamin D toxicity, anyway, gym supplements may be taken by a patient in excess amount. Excess of vitamin D will cause calcium to rise. In sarcoidosis, we have granulomas. We have non-caseating granulomas, and what these non-caseating granulomas contain is an enzyme which is traditionally present in you and me in our kidney, that is 1-alpha hydroxylase. So this 1-alpha hydroxylase enzyme would be responsible for synthesis of vitamin D3, and therefore when you produce vitamin D3 in the granulomas, then the values of calcium are bound to rise. Milk alkali syndrome would be excessive antacid abuse, and primary or secondary to this excessive antacid abuse, the calcium values will again be rising in the patient, but hypoparathyroidism would be having less of calcium. The correct answer for the current question on this slide, that would be 35, would be option number C. Now we have a 40-year-old man who has fallen from a height. Maybe he's a construction worker. He was not using safety cable and he fell down from a height on his back, and he's developed a paraplegia, paralysis of legs. The key word in the question was central cord injury, and the question was saying which of the following is false about this case. Now he gave a combination of upper motor neuron lesion and lower motor neuron lesion for upper limb and the lower limb. My point is as simple as this, that if an individual is having damage to his spinal cord, suppose the damage occurs to the C-spine, cervical spine in a patient, then at the level of the lesion in the upper limb, there will be lower motor neuron lesion. But below the level of the lesion, upper motor neuron manifestations will occur. You can understand now why upper motor neuron is a misnomer, because traditional impression of upper motor neuron is above the level of the lesion that is in the brain. But upper motor neuron is actually corticospinal tract lesion. Guys, please remember, every time corticospinal pathway is affected in the spinal cord, in the brain it is involved, understandable, but even in the spinal cord if it is involved, it would still cause manifestations of upper motor neuron lesion, because corticospinal tract whenever is involved will have spasticity and brisk reflexes. So if you have a cervical spine injury in a person, then at the level that is in the arms there will be flaccidity, But below the level, that is in the legs, there will be a spasticity present. So the bottom line is that every time you have a, let me say, thoracic spine trauma, then in those individuals, arms would be spared. Then there would be no problems with respect to the upper limbs of the individual, but whatever is the thoracic nerve root that is getting involved, whatever is the thoracic vertebral level which has got involved, and the nerve roots that are getting involved, at that level there would be lower motor neuron lesion, and below that would be upper motor. So option number B makes more sense here. Lower motor neuron lesion, flaccidity, like C spine was injured, so there would be flaccidity in the upper limb, but in the legs there would be a spasticity, so B makes sense here. Now, if you focus on option number C, bladder and bowel activity and sensory supply to the perineal region can be preserved. The traditional impression is spinal cord injuries, you might be having a bladder involvement. So let me just show you a diagrammatic representation of central cord syndrome. In central cord syndrome, the corticospinal pathway would be involved. Now see what happens. Cervical fibers are present medially, then is thoracic, then is lumbar, and sacral fibers will be present most laterally. So as you can see, if you're gonna be having, if you look at the pointer here, you can see that in central cord syndrome, cervical spine will be involved, but sacral sparing will be occurring. And because of the fact that there would be a sacral sparing occurring in the person, that means the bladder and the bowel of the patient, because there is a sacral sparing occurring here, so I can say that the bladder and the bowel of the patient might escape injury as well in a person having a central cord injury syndrome per se, central cord syndrome per se. So option number C is a correct one. Now you are left between A versus D. D says dissociative sensory loss. Now the pathways which are involved in this case are the lateral spinothalamic pathway, and because the central cord syndrome would again occur in a very asymmetrical fashion, so there can be a development of dissociated sensory loss. The meaning of the word dissociated sensory loss is that the sensory loss does not occur all over the body. It is mainly over the neck area and the shoulder area in a cape distribution. This is what the textbook says. In patients who are having a central cord syndrome, the manifestations would be a dissociated sensory loss. Means there is loss of pain and temperature. When I say dissociated, it means only two sensations are affected, because lateral spinothalamic pathway carries only two sensations only, pain and temperature. So only two would be lost in the patient, over the shoulder, over the neck, and the upper trunk area. So dissociated sensory loss is the term that I want you to remember for not only syringomelia but even with patients of central cord syndrome. And apart from it, there can be even arm weakness, as is shown here. The arm weakness will occur out of proportion to the leg weakness in an individual. That's because the cervical fibers are present more medially. So there is a possibility that leg muscles might still be spared in the patient, but sacral sparing can definitely occur, because of which the bladder involvement may not occur. So if you look at the options in this particular question, both I would say all three of them, B, C, and D, make sense. Why B makes sense? I said at the level of the lesion, lower motor, below the level of the lesion, upper motor neuron lesion. That's standard medical college teaching. So B makes sense. C, because of the sacral sparing component, as I explained. Let me just use a finer pen to write it, the data here also. I'll repeat this fact. I said sacral sparing is a possibility because sacral fibers in the lateral spinothalamic pathway as well as in the dorsal column are present most laterally. So because the sacral fibers are present laterally, that is why the bladder and the bowel sparing can occur. And the dissociated meant, I said pain and temperature, only two sensations would be lost because of the involvement of the lateral spinothalamic pathway in the person. Option number B is due to corticospinal pathway involvement, and option number D is because of the lateral spinothalamic pathway involvement. The correct answer for this one would be option number A, which is ulta of option number B that is written. So some people, like they said, sir, we were only confused between A versus B only, and it is that they had to use then logic of first year of medical school, where they always teach us at the level of the lesion and below the level of the lesion, the manifestations are different. Coming to question number 38, again a micro/medicine based question. A 20-year-old boy with fever for last 5 days, and he's drowsy and he's going into coma. Every time we have a patient from rural India, like in exam in the previous years, he was mentioning a student brought in from Assam, or he mentioned a soldier brought in from Chhattisgarh. Wherever there's going to be lot of green cover present, lot of water bodies present, there are bound to be mosquitoes, and because of mosquitoes, falciparum malaria would be present. There would be cerebral malaria developing in an individual. I mean, every time you have fever and CNS manifestation, cerebral malaria is the concentration, and currently we do not use chloroquine for these patients, but we rather use that Chinese anti-malarial drug, that is artesunate, for the patient. Some people even mentioned dosages were given, but you don't need to get into the dosages per se. You just need to remember that for falciparum malaria, we are using artesunate. In majority of states, I would say quinine resistance is present. Coming to question number 39, he says the following fungal infection of the lung shown in the chest X-ray presents as which of the following? So there was a circumscribed shadow that was present, and that tells you that there is a cavitation. I'm saying this could be a query aspergilloma in an individual, and because there is a fungal ball growing in this person, invasive aspergilloma can also contribute to angioinvasiveness, and he could have a life-threatening hemoptysis as well. Option A says lung abscess. Now that's unlikely because he's himself talking about fungal infection in the lung. So I would like to keep this as unlikely as an answer. There is no pulmonary edema visible in this question. There's no bat wing edema present. So option number B is ruled out. Pleural effusion, the costophrenic angles look fine. So I'm ruling out option number C also. That leaves me with only one cavitation. The diagnosis of this patient is a query aspergilloma. There could be a fungal ball growing in the lungs of the patient in the right upper zone. Coming to the next one, he talked about a HIV positive patient with a low CD4 count. He's having nuchal rigidity. So every time you read a HIV positive patient with nuchal rigidity, you are thinking in terms of cryptococcal meningitis. The CSF sugar of the patient is 70. Blood sugar was 100 at that point of time. So luckily at the moment, maybe early diagnosis has been made. There has not been a fall in the CSF sugar in patients of cryptococcal meningitis. Why am I suspecting cryptococcal meningitis in this individual is because he is AIDS positive with a low CD4 count. The CSF sugar at the moment is normal, though can be lesser as well. That's the interpretation at the moment. The CSF protein of this patient is slightly elevated. You see, normal CSF protein is 15 to 45 milligram percent. Here it is 50, so slight increase is present. That is telling you that there is a CNS infection because antibodies are being produced. And India, in case showing presence of capsulated organisms, will help us in confirming that he is talking about cryptococcal meningitis only. Now, what would you do for the management of these patients? You would give these patients liposomal amphotericin B and 5-flucytosine. Because there would be an irritation of the coronal plexus and inhibition of reabsorption of CSF, so pressure in the brain would be elevated. Majority of cases, MRI can be normal. You see, in the late presentation, in the routine video, I've talked about a soap bubble appearance on an MRI head, but you're not going to see it regularly. So soap bubble appearance on an X-ray distal head of the radius is osteoclastoma, but soap bubble appearance on an MRI head is cryptococcal meningitis, but that would be in very florid infection, very late presentation. Majority of cases, it would be normal. D says cryptococcal antigen level more than 1/32 is a good prognostic marker. So I'll just go by bluffing an answer here that if the values given to be of the antigen more, then it can be not a good, but it would be a poor prognostic marker. The correct answer for this one would be A, B, and C, and I'll just show you the textbook reference also. It is mentioned in Harrison that if you encounter high CSF pressure, if you encounter pleocytosis, low CSF sugar, in our case it was normal, and the titer of antigen being more than 1:32. Thus, I'm talking about cryptococcal reactive antigen. Then cryptococcal antigen in the CSF more than 1:32 dilution, along with possible hematological malignancy, usage of steroids in an individual, they are all basically poor prognostic markers. So you don't need to cram up the list, but the bottom line is that anytime CSF sugar is lesser, pressure is highly elevated, there is more presence of antigens, that ensues bad prognosis for the patient. The correct answer for this question is option number 2. The next question says an old man comes to the emergency room and he asked in which scenario would you do further investigation of the patient. So in the first one, worst headache of my life points to subarachnoid hemorrhage. So I would like to do a non-contrast CT head so that I can demonstrate blood in the sylvian fissure so that the diagnosis can be made and nimodipine in the patient can be started. Worsening of headache with diplopia, that's a feature that indicates that there's a possible raised ICP in an individual. You see, sixth nerve involvement is a feature of raised ICP. We call it a false localizing sign because the problem is not in the sixth nerve, but it gets involved because it has one of the longest intracranial routes. So in any patient of raised ICP, again, neuroimaging would be required. Headache not relieved in 4 hours. Somebody is having a respiratory tract infection, sinusitis, person could be having a headache which might last for maybe 1 day or 2 days. And as the URTI clears off, the headache would also disappear. So C, I would not say would raise an alarm bell. A and B are indications for further investigation, and the main issue in the exam was that should we consider point number D as well. I mean, in option number C, I'll not do any workup in the patient, but D, first severe headache. So let's look at what Harrison says. There's a table in volume 1 where he's mentioned about sudden severe headache, first severe headache. Now, what he implies by first severe headache is that this person could be having is a brain tumor, and the initial part of the disease process might be only having projectile vomiting, but once the CNS mass becomes big enough, then it can cause a excruciatingly painful headache that will be worse in the patient in morning hours, and especially with changes in the position of the head, the headache of the patient can even worsen as well. So there are a couple of criteria like pain induced headache worsening on bending forwards, headache which is worsened by coughing, like especially if you are talking about, let me say, a post lumbar puncture headache, then that is worsened by any condition that increases intra-abdominal pressure like bending forward or coughing as well. So every time you're having these terms written like worst headache of my life, sudden severe headache, or pain headache which is induced on bending forwards associated with the false localizing signs, the subsequent part is relatively easier. I mean, if the person is having giant cell arteritis, the age will be more. There might be even pain in the distribution of the temporal artery. So you don't need to remember all of these. But yes, this peculiar term was mentioned in the exam, first severe headache in a patient. And yes, that is also an indication for doing further workup. So I would rate this as a slightly difficult question. A lot of people answered only A and B, but the correct answer for this one is point number 3, that is option A, B, and D are correct. For D, I had to anyway look up Harrison. So don't worry in case you got this one wrong, doesn't matter. I mean, there would obviously be some of them which would be direct lines picked up from the textbook, and therefore the chances of them getting them wrong would be relatively higher. The next one, however, was the balancing act done by the authorities, that they asked about signs of heart failure, non-pulsatile elevated JVP. This is a classical feature that you encounter in cardiac tamponade. You see, the pressure is so high that the JVP pulsations disappear. There are only 2 scenarios where I've described that there is a non-pulsatile elevated JVP, that is superior vena cava thrombosis and then cardiac tamponade. So this is not a feature of heart failure. It's rather when intrapericardial space pressure is more than the left ventricular end diastolic pressure. Orthopnea is a feature of heart failure. Yes, that means dyspnea in mainly a person in supine, when he goes into supine position. Option B and C basically mean the same. Orthopnea would be dyspnea in supine position. When he will lie down in the bed, after 1 or 2 hours, he will start feeling miserable. And if a person is having right ventricular failure, then there would be congestion in the liver. There would be stretching of the capsule of the liver. So there would be a hepatomegaly. Stretching of the capsule of the liver would contribute to right upper quadrant pain. So option number B, C, D indicate that there is a heart failure, but option number A is the feature of cardiac tamponade, which is why it has not been included in signs of congestive heart failure as asked in this question. The next one talked about this 65-year-old lady with a long-standing history of constipation, menorrhagia, cold intolerance. Cold intolerance tells you thyroid problem is there. There is a non-pitting edema of the extremities, which means that there is a lymphedema, and now she's become drowsy with altered mentation. So first of all, I know I'm dealing with a case of hypothyroidism. Just put down arrows to say T4, T3 or less of there is a hypothyroidism. There is also a lymphedema described in the patient, and now there are CNS problems in the patient. Every time you read about CNS problem in a person having hypothyroidism, then there are 2 differential diagnoses which must be considered in the patient. One of them is myxedema coma, because if hypothyroidism patients are non-compliant and they suffer from an intercurrent illness, like this hypothyroidism patient lady, she is not taking medicines and she is suffering from a UTI, then there could be triggering of myxedema coma, where body temperature will become less than 35 degrees Celsius, because thyroid hormones in the body are mainly responsible for calorigenesis, that is heat production in the body. If calorigenesis component is reduced, if the heat production in the body itself is lesser, hypothermia can ensue, and therefore in these patients myxedema coma can occur. Another reason why you could even be having seizures and myoclonus also. Myoclonic seizures is a rare presentation which is usually responsive to steroids, that is Hashimoto's encephalopathy. These are 2 differential reasons for CNS problems that could be developing in a hypothyroidism patient. Heart failure was anyway dummy choice in this case, so was ketoacidosis. So we were left with Hashimoto's disease and myxedema coma. You see, one of the important causes of hypothyroidism is Hashimoto's, agreed. But my point is the main reason why we need to give answer as option number beta is that altered mentation component and drowsiness. I mean, that's not a presentation that you get with Hashimoto. Everything else in the question, hypothyroidism, Hashimoto's causes, ultimately antibody mediated damage, so understandable. But I am answering this as option number B. The main reason is the CNS manifestations which were described in the question, which will enable us to identify this as myxedema coma. Then levothyroxine and liothyronine along with space blanket and management of hypothermia should be used for these patients. The reference from the Harrison is anyway mentioned. The next question mentioned about a female patient who's presented to the casualty. She's a known case of chronic stable angina. She comes with severe fatigue and prostration, and when the doctor is taking the blood sample of this lady, the blood is having a brown hue. More of forensic slash I would say more of forensic medicine than general medicine. But yes, when he's talking about chronic stable angina, it was a two-step question, because you know that nitrates exposure causes a development of methemoglobinemia. So all patients of chronic stable angina, because they develop chest pain, so they'll be on short-acting as well as long-acting nitrates. They might be on isosorbide mononitrate as well, and as well as they might be on nitroglycerin buccal spray as well. But once these patients are on nitrates, then these nitrates can cause Fe2 plus and hemoglobin to be converted into Fe3 plus. Once you have is oxidized hemoglobin being produced, this oxidized hemoglobin will not carry oxygen. Normally Fe2 plus carries 4 atoms of oxygen. Now it will not carry oxygen, and therefore there would be hypoxia, and this oxidized hemoglobin also explains this chocolate or brownish discoloration of the blood. This oxidized hemoglobin is what is called as methemoglobinemia. Carboxyhemoglobin anyway would be causing a cherry red discoloration, and the remaining options were anyway dummy choices in this question. Coming to the next question, a proper blood report was given. Hemoglobin was 7.4, MCV and MCH were lower, as you can see here. And this was a microcytic hypochromic anemia, and the serum iron of the patient was low, and ferritin of the patient was slightly elevated. And he said, what is the interpretation? So I can easily rule out iron deficiency anemia because ferritin values would be lower in iron deficiency anemia. I can rule out thalassemia because ferritin would either be normal or would be elevated grossly in these patients if there is a secondary hemochromatosis. Then there's no history of blood transfusion also described in the question. When it comes to sideroblastic anemia, then iron and ferritin values both would be elevated. In this question, as you can see, serum iron of the patient is on the lower side, and it's rather ferritin which is elevated. So this would be ACG, that is anemia of chronic disease. If you go through the table, I have already explained in the routine videos. In iron deficiency anemia, iron and ferritin both are low. In sideroblastic anemia, iron and ferritin both are elevated. So that leaves you with only one combination to be answered: less serum iron and elevated serum ferritin. That's because hepcidin inhibits the release of iron. In anemia of chronic disease, there is release of cytokines. They interfere with the functioning of hepcidin, and hepcidin being the top boss in iron regulation, it will inhibit the release of iron from the stores. So the stores are saturated, stores are full, ferritin will be normal to slightly elevated, but then because iron will not be released, so serum iron values would be lesser. The correct answer for this one is option number C. Coming to the next question, he asked you to interpret a spirometry, and most cases when they look at TLC, which was lesser, it meant that there was a possible pulmonary fibrosis in a patient, total lung capacity being lesser, FEV1 also being lesser. So the first interpretation was this was pulmonary fibrosis. Now, why this is not pulmonary fibrosis is because if it is pulmonary fibrosis in a patient IPF, then the fibrosis will cause residual volume to be lesser. Look at the residual volume of this patient. The residual volume of this particular case is turning out to be rather 120% of what it should be. Now, how that is possible, I'll explain to you, but the first point of mine is the answer to this question cannot be B, because the residual volume will always be less in idiopathic pulmonary fibrosis, because when I say the word fibrosis, the whole lung is smaller. Option number A, bronchiectasis, is an obstructive airway disease. In every obstructive airway disease, there can be air trapping, so TLC would be rather increased in the patient. So I'm ruling out option number A also, bronchiectasis. Why? Because total lung capacity would be normal to increased in obstructive airway disorders, because we have is a air trapping. We are left with sarcoidosis, which again causes a restrictive lung disease and neuromuscular disease in the patient. Now let's consider myasthenia gravis as one of the prototype examples of myasthenia gravis and examples of neuromuscular disease and work it out. You see, imagine a myasthenia gravis patient sitting on a chair next to you and you asking this person to breathe out as hard as he or she can. If a myasthenia gravis patient will try to breathe out because there is easy muscle fatigability, few first breaths they might be able to do activity like you, but then their diaphragm will begin to tire out in when you make them do increased work of breathing. So in people who are having myasthenia gravis because of easy fatigability, they will not be able to push exact amount of air out of their lungs just like you and me would do. Therefore, in these patients, the air remaining behind in the lungs would increase. I'll repeat that again. I said, if you ask a myasthenia gravis patient, let's assume a lady with myasthenia gravis is having myasthenic crisis. You're asking her, ma'am, breathe out as hard as you can. Couple of breaths. She's already in crisis. Muscles will tire out very soon. So she will not be able to breathe out as fast as you and me can. And therefore, the amount of air remaining behind in the lungs of these patients will increase. This would be a feature that would only be seen in patients who are having myasthenia gravis or neuromuscular disorder. The correct answer to this question is option number D. How sarcoidosis has been ruled out? In sarcoidosis, if lymph nodes are pressing on the airway, obstructive pattern. Whereas if there is a pulmonary parenchymal involvement, reticular opacity is present, then there is a restrictive pattern present. But even in sarcoidosis case, residual volume would not be increased in a patient. The key feature in the spirometric interpretation was an increase in the value of the residual volume. I mean, if you miss this out, this can be wrongly answered in the exam as idiopathic pulmonary fibrosis and even sarcoidosis, because even that contributes to restrictive lung disease in the long run. I said in sarcoidosis, two things. Initially, lymph nodes are bigger, so that can be obstructive. But in the later part of the disease, the same patient could be having is a restrictive pattern. B and C both can produce a restrictive pattern in the later part of the illness, which is why option number C has also been ruled out. The correct answer is neuromuscular disorder. Then was a HIV positive patient who presents with fever with non-productive cough and breathlessness. X-ray in the chest is normal. Now, initially, I'm thinking it could be a URTI, it could be COVID. COVID Delta strain was causing pneumonia, but Omicron is causing only URTI symptoms. But then there's a keyword LDH in the patient is elevated. LDH can be elevated due to multiple reasons like hemolysis, but LDH can be released even via damage to lungs as well. Plus CD4 count of the patient is less than 200. The common opportunistic infection by the name of pneumocystis jirovecii has this peculiar presentation. In majority of cases of pneumocystis jirovecii, X-ray can even be normal. In some cases, you might even have is a bilateral hilar shadows. That bilateral hilar shadows is anyway, I would say, less common a presentation. I mean, it takes a while for the radiological features to evolve. If a patient will come relatively early, the bilateral hilar opacities would not be seen, X-ray would be normal. But considering LDH values to be elevated, and more importantly in the patient, the CD4 count of the patient is lesser, so I have to give cotrimoxazole to these patients with steroids. Why do I need to give steroids to this person is because usually when you give cotrimoxazole, there is worsening of the features. When you kill this organism, the fungal infection, it causes worsening of the patient. Same was happening in Delta also, no? Like in COVID patients, when you were treating them, in the later part, they were having a cytokine storm. So even in COVID-19 pneumonia, we find, in fact, in all pneumonias, we find when we treat the patient, oxygen saturation start dipping. Relatives are fighting with us. Why is the patient not improving? That is because there is a massive release of cytokines in all cases of pneumonia, both bacterial or viral or fungal pneumonia. And subsequent to that, mainly bacterial and viral primarily, then the patient would require steroids. I'll just show you the reference from Harrison as well. He says that LDH values are elevated as a result of pulmonary damage, as you can see. And second, what he says is glucocorticoids reduce pulmonary inflammation. So they are the ones which would be used in a patient who would be suffering from pneumocystis jirovecii pneumonia. The page number of Harrison is anyway mentioned where the usage of steroids is mentioned. I mentioned that in my routine video as well. So the correct answer for 48 is option number beta. Coming to 49, if there's a 45-year-old man with hypertension, he has currently developed diabetes. His lipid profile is showing a low HDL, high triglycerides and high LDL. All diabetics would be having both a derangement of triglycerides as well as LDL. If only triglycerides are elevated, like suppose in this question, triglyceride value was given to be more than 500. In those circumstances, if triglyceride values were alone elevated, then my primary weapon that I'll be using for isolated hypertriglyceridemia would be fenofibrate. But in this question, it is a combination of both the bad cholesterol as well as triglyceride that is elevated. So to put brakes on, I would like to use in this particular patient statins, that is HMG coenzyme A reductase. Hypertriglyceridemia and elevation of LDL is the standard feature in diabetes mellitus. These patients should always be put on high intensity statins. Now, there are two statins which are given in this question, that is atorvastatin and rosuvastatin. Which will I select? High intensity statin dosage for atorvastatin is 80 mg, for rosuvastatin is 20 mg. Why answer to this question is not B is because rosuvastatin dose is given to be 10 mg, it should be 20. Slightly a difficult one. I'll show you a table for it which will make it easier. Rosuvastatin with fenofibrate. This initially looks very attractive, but Harrison does not mention it, neither does American Diabetic Association. In fact, Harrison says this. Harrison says that apart from pharmacological therapy, all patients with diabetes and atherosclerotic risk factors, cardiovascular disease, remember he's hypertensive, he's having diabetes, so he's having atherosclerotic cardiovascular disease. He says all patients with diabetes and documented atherosclerotic cardiovascular disease should receive high intensity statin therapy. As far as high intensity statin is concerned, the objective would be to lower the LDL of the patient on a daily average by 50%, and it is a dosage of 40 to 80 mg for atorvas, and rosuvastatin would be 20 to 40 milligrams. Moderate intensity statins would be causing a lowering of the value by about 30 to 49%. And if you are going to be using low intensity statins in some patients, then they would lower LDL by approximately 30%. I would like a good response, because the target LDL that you want in a diabetic should be less than 70. So if I want to give high intensity statin in a diabetic, yes, it is atorvastatin which is usually recommended. And even if there is a kidney involvement, one more statement, atorvastatin, I'll just remove the blue marking from here. He also says this statement, which can be a future question, that atorvastatin is the statin of choice in patients with renal disease. So diabetic with renal involvement, it is atorvastatin that is recommended. And the answer to this question is option number A. Still, if you're not satisfied why the answer is not C, then I can say that the side effects of both statins and fenofibrate would add up. The muscle weakness component is fairly pronounced. I mean, if you talk to people who are taking statins, they'll always say, sir, I always feel tired, always feel weak, and their CPK MM values might be slightly borderline elevated as well. So because statin-associated myopathy can be present, if you add fenofibrate to it, it can worsen. And diabetic patients anyway feel weak half the time because of the hypoglycemia component, which could be occurring if there is an autonomic neuropathy developing in these patients as well. So per se, I can say that the initial approach in all diabetics with atherosclerotic risk factors, he is hypertensive. Now he has become diabetic as well. And he's saying, what are you going to do in this case for management purposes? So what I'm going to do is use high intensity statins, which is why the answer to this question is option number A. Fenofibrate is only to be used if there is isolated hypertriglyceridemia with values spiking more than 500, because that can even trigger acute pancreatitis. Then was again a paper 2 question, Hammond-Crunch sign, very classical. Like it would be somebody, I mean the Hammond-Crunch sign is an auscultatory finding. I've described that in my pneumothorax video as well, and even pneumomediastinum as well, which could be seen with Boyrab or with bullet injury to the chest or stab injury to the chest. It is as if somebody is walking on snow. Like imagine you are in a hill station, freshly fallen snow is there, and you're walking on snow with heavy duty leather boots. So somebody walking on snow with heavy duty leather boots is the presentation of auscultatory finding of Hammond-Crunch sign. It is encountered in patients with pneumomediastinum. So it was more of I would say a neat kind of a paper where some questions were very, I would say, fact-based and some were obviously conceptual. So as you would have noticed in the discussion that I've done, I mean, some of them are like you read the term and you know. I mean, obviously you will not confuse Homan sign of deep vein thrombosis. All of you know that ankle dorsiflexion will cause severe pain. So none of you would ever confuse Homan sign or deep vein thrombosis with Hammond-Crunch sign. I'll just use alternative color to highlight that. I said if a person is having deep vein thrombosis, then it is Homan sign that comes up. So a bit of, words or terms which might be sounding similar, but this one is Hammond-Crunch sign. So these are the details that I would like you to remember for this discussion. Keep the pressure on, guys. Keep on learning new facts every day and you'll come out with flying colors. You'll break on to the other side, as they always say. So keep hammering, and my best wishes to you in your success, in your future endeavors, which will definitely be successful.